Okay, if you don't have your video on, if you could please turn it on so that does not impact your PPS, that would be fantastic. Okay. All right, so for today, the excitement will be to finish chapter 18, and then we're just going to look at the plastic instruments one more time, or at least one more time. Again, should I say? I removed a couple of the instruments, like the ones that all look the same, and we just left the Stevens scissor, the facelift scissor, and the littler scissor. Not to be confused with the bigger scissor, okay? So we will look at those, and then we have a post test after that. That'll be open at 11:30. And let's see what else. Make sure you're uploading your stuff to Blackboard. Did you see my announcement yelling in red and bold? I hate putting zeros in the grade book. That's my worst nightmare. So especially when you're here, like for the virtual labs, you're here, you participate, you do the activity, and then I can't give you attendance because there isn't a silly Blackboard thing. So you miss out on the points, you miss out on attendance, and then that hurts your PPS. So there is a hiatus as far as the 2-day maximum to be able to turn in stuff. So if you have something that is outstanding that you have not turned in, please turn it in. Anywhere there's a 0, fill it in with something so that I can give you some points, okay? Questions about that? I like to give points. That's my favorite thing to do. Okay. Other than that, just another reminder that Saturday is going to be our lab organization, cleanup, storage, shenanigans. If you can attend, that would be fantastic. We're going to start around 9 a.m. and work until we're done. So I'm not sure what time that is, but I do know at noon, I will be providing pizza for us. So lunch will be provided. Sean asked a great question. Do you have to wear scrubs? No, you don't have to wear scrubs, but we are going to be bending and moving and pulling and probably in like a dirty storage area. So that's what we have going on. So if you are going to be there, first of all, thank you. And then second of all, you know, wear something that's conducive for that type of manual labor. Okay. All righty. Any other questions for me at this moment before we get the party started? Okay. All right. So here's the deal. I have a PowerPoint that I would like to share with you. And I'm working on SUR 120. I'm excited about that. Full days in lab. It's going to be amazing. Okay, stay tuned for that. That's just a little teaser. Okay, I need to present. Aha, let's start from here. Ta-da! Okay, that was the end of the first part. So I'm gonna start the second part here. Okay, so as you probably remember, we're in chapter 18 and we stopped just before positioning. So that would be around page 356. So that's where we're at. That's where we're going to pick up the story. So we're going to kind of do something similar to what we did for the virtual lab, where I'm going to break you up into groups and you're going to look at the positioning and then we'll discuss them. So you guys get some engagement as well. So, but first we're going to talk about a couple different things. First thing is, what is the role of us? So the role of us, making sure that we have an understanding of how the table works. Most tables work the same, and you'll get familiar with the table that we have and the remote that goes with it, and how to lock it and raise it and lower it and all of those fun things. And we've started playing with that. So just know that while most tables are very similar, there are some differences. So make sure that you familiarize yourself with that. Would have to say, when I first started scrubbing, I might have been a student still and in my clinicals. And I can remember distinctly my preceptor and I were scheduled to help with a DNC procedure. And of course, that takes the stirrups for positioning. And so we got everything open and set up. And for a DNC, a lot of times we'll just throw on a pair like open glove and set it up and then scrub in later if that's the policy of the facility. So we did that, and I set it up actually. And so we were done and the patient wasn't in there. And I said, should I get the stirrups, you know, the positioning stuff? And she's like, oh no, that's the job of the circulator. We don't have to worry about that. And I knew it was within our scope. So I just said, well, do you mind if I get the equipment just so that I can familiarize myself with where it's located and all of that stuff? And she's like, no, sure, go ahead. So anyways, I think the takeaway there is, one, help out your circulating nurse. They have a lot of things to do. And if it's within your ability and your capability and your time, and it makes sense, help them get the video tower, help them get the positioning equipment, whatever you can do to help out, right? It wasn't, in my mind, a really good example of a team mentality. So familiarize yourself with the table, familiarize yourself with the positioning equipment and how it goes on. We'll do some of that in the lab. So you'll gain a little bit more working knowledge of that, okay? Understanding each position and associated devices. So again, if you are doing a hemorrhoidectomy, there may be a couple different patient positions that the surgeon could use. One could be Kraske, one could be lithotomy. I've seen both. So have an understanding of what positions are most commonly associated with the procedure that you're doing and what preferences the surgeon has. You could do lithotomy with Allen stirrups, which are the little boots that like support the foot and leg, or with the candy canes where the feet just kind of hang in these little stirrup things. Being proactive, again, if you're not sure, you ask, check out the preference card, talk to your preceptor, talk to the circulator, see if there's equipment that you can get, that you can help with. You know, if you're not scrubbed in on that case, maybe you can be like the assistant circulator and you can help with positioning and those kinds of things. If you're setting up for a procedure and this is kind of happening behind the scenes, it's also important for you to take a moment and just kind of check things out, right? Wear that extra pair of eyes, wear that extra pair of ears, and it's always good to have an extra individual kind of take a peek at the patient positioning, right? There's been more than once when I was doing like shoulder scopes and they put the patient in like a semi-Fowler's position, and there's this special positioner that holds the head, and it's kind of difficult to get the neck and head in some sort of normal positioning. So the more eyes on that, the better, to make sure the head isn't this way or that way or too much forward or too much back or whatever the case may be. Okay. If you're doing something like a lap chole and you see that scheduled, remember the bed gets turned for that. And sometimes the surgeon likes a footboard. That turning of the bed is going to accommodate the C-arm. So that type of proactive approach is always important. And then, you know, just being that extra eyes and ears, and then communicating. So I know we're just kind of getting into this whole thing called Surg Tech, but, you know, I'm seeing you guys as teams starting to talk with each other and work with each other, you know, tell each other what you're doing. When we were moving patients yesterday, I saw you guys doing that. And that's exactly what we need to do. If we're going to walk away from a patient, if we're going to move an arm, if we're going to get the gurney, if we're going to remove the strap, whatever the case may be, you know, just being over communicating, I guess I should say. What questions do you guys have about the role of the Surg Tech in positioning? Nothing? Okay. Principles for safe positioning. So again, making sure that we have the right stuff. I think I gave the example of a situation where my circulating nurse was really new to the operating room, not new to being a nurse, but new to the operating room, and had attached the Allen stirrups to the wrong part of the bed. So again, if you're with someone that you know isn't as experienced, it is a good thing to kind of keep an eye on what is happening and make sure they have the right stuff. And if you've worked with a surgeon a lot, but you haven't worked with that circulator before, you know that they don't know the specifics that the surgeon likes that you know, then tell them. Right? Well, Dr. So-and-so really prefers this instead of that, or whatever the case may be. Making sure we have enough people, that's always a thing, right? Being familiar with the position. And then making sure that the table is locked, and making sure you establish a director. And a lot of times that's anesthesia. Predominantly anesthesia. And the table being locked, the gurney, the OR table, really important. Do the hip check, make sure that it's locked. Moving slowly, controlled movements, and taking care not to hurt yourself, right? If the table's too low or the table's too high, when you're moving the patient, that could cause an injury to yourself as well. And then the patient's normal range of motion, right, also has to be taken into consideration. And then this is a word that I made up, but I think it really works. Watch for tangulomas, right? So what do you think I mean by that? Coffee break while you guess.
Just making sure that the IV tubes and cautery lines and everything else isn't like creating a noose.
Yes, exactly. Cords are the bane of my existence in the operating room. I swear. It seems like no matter how careful I am to coil them or place them, like they always want to jump into a big frayed knot. So just watching out for cords and tubes and all of those things as you're moving patients to and fro is a good thing.
Don't be kinking those catheters.
I don't kink the catheter. Don't pull out the IV. and you know, on some cases, this probably doesn't have to do as much with positioning, but it just makes me think about when you're working in and around the face and mouth, the patients, if they're under general anesthesia, they still have to have a tube in. So there's a special drape because that tubing, the ET tube and the ventilator tubing isn't sterile. So there's a special little draping thing that we have to do. It's like this little cylindrical plasticky tube like drape. And so we're working around the tube that whole time. And so a couple things with that is the ET tube, you'll notice it has numbers on it. You want to note as the surg tech where the teeth, like what number the teeth are at. I know this sounds really weird, but this is just a tip I'm going to give you while I'm thinking about it, because you want to make sure that that tube does not go in any further or out any further, because you might be moving that tubing over to the left or moving the tubing over to the right. And anesthesia, a lot of times when we're doing like facelifts, will be at the feet. Like we'll take the bed and we'll do this to it, and anesthesia's at the feet, and we're at, you know, we're still on the opposite end of anesthesia, but we have the head at our end and anesthesia has the feet. And that tends to make them a little bit twitchy. So you gotta just be careful with making sure nothing gets tangled around that stuff as well. Okay, questions about any of those things before we move on to our discussion about positioning, different types of positions, and other stuff. So I have a great video we're gonna watch in a second. It's about 15 minutes long, but it gives us a fantastic tour through a variety of different positions. So I think it'll be really awesome for us. So I'm not gonna say too much about the OR table, except for, again, be familiar with the table, make sure that it is locked, because as I said in lab yesterday, when environmental services comes in to clean the room, if you have that, the only one place that I ever worked at was I lucky enough to have somebody that was deemed that to come in and clean the room. It was just the responsibility of the staff. But they'll unlock that OR table, move it to the side, mop underneath it, and then it gets moved back. Just make sure that it gets locked. Always check it. I don't know how many times I've come in and leaned against the OR table, just even accidentally, and it's shifted to the side. So make sure that that's locked. And then, of course, padding. Like we want to take into consideration, I don't know if any of you guys saw my announcement, but I found this great image of all of these like positioning pads, and they're kind of all along the bottom of the slide. There are tons of them. We just want to make sure that we're padding any bony prominences and protecting nerves and all of that fun stuff. We kind of have to be really proactive, because with general anesthetic, the patient can't tell us, right, if they're hurting or not. So injuries and prevention, again, nerve and vascular injuries, we want to prevent compression. I think Monday, one of the groups mentioned if we are doing a C-section or something like that, baby, when mom is laying flat, baby's pressing directly down on the major vessels of the body. So we want to put a little bump under the right hip. It kind of shifts things over to the left a little bit. If we have a really large patient, we might want to use a little bit of reverse Trendelenburg. Anesthesia is going to facilitate those things for the most part. We talked about shear injuries. So that's when whatever's underneath the patient is either staying still or moving in one direction and the patient's going in the other, right? And when we have these frail little old peoples, we can just take their skin right off when we're moving them. So instead of sliding them across something, the best we can to lift to prevent that is better. Skeletal injuries are another type of injury. Normal range of motion. Remember, in supine, we want the arms less than 90. And then there is the risk of embolism, right? So what devices do we use to lower that risk of DVT? Anybody remember?
Blood thinners?
That's a good guess, but this is actually a device that we use in the operating room.
Is it something that goes on the legs that does the contracting, or
Yeah.
or like the compression stockings maybe?
It's
Okay.
similar to that. They're called sequential compression devices, SCDs. That's what we call them a lot of times. And there's different varieties. There's ones that just go on the feet. I don't know how in vogue those are anymore, but they are called PlexiPulse. Also ones that just go on the calf, and also ones calf and thigh. So it just kind of depends. But the premise behind it is when you think back to anatomy and how we discussed how blood is returned to the heart through the vascular system, through the veins, venous return is by skeletal muscle contraction, right? So if we're just laying there and we're not moving, or the patient's just laying there and not moving, blood has a tendency to pool in the veins. And then that could increase risk of clots. So these are like these little pneumatic, like squeezy stockings, and they will rhythmically squeeze the calf or the foot or the thigh or whatever, or all three, to help prevent that. So it's pretty much standard of care that every single patient that comes into the OR, they get a pair of SCDs. They're single-use devices. And we do have some in the lab, so we will put those on the patient. We'll take a look at those a little bit more closely. We don't have a machine, but let me tell you, when I was in Tucson, we moved surgery centers. You think moving a house is fun? Move a surgery center. They built a brand new facility for us, which was amazing. We shut down for 2 weeks to move everything, and they bought tons of new equipment, and, you know, we had to help assemble it and, you know, decide where it was going to go and blah, blah, blah. So one day we snuck in one of the OR rooms, and we had got all of these new SCD machines. And so me and like 2 or 3 other surge techs, we took turns wearing the SCDs and just like sitting around in the operating room. And they were just the ones that went on the calves. But man, it's like getting a nice little massage when you wear those things. So yes, sequential compression devices. Respiratory compromise, again, if we have a really heavy patient on their back, or if we have a patient prone. Those are 2 situations. And then falls. And I told you about my experience of the patient falling off the table during lap chole. Yeah, we don't want patient falls. So being proactive and then just identifying risky situations, I think, is our best way to avoid that. Questions about that? Okay, here's our video. We're gonna watch that next. Maybe. Play, monkey. Oh, go there. Some assembly required for the fracture table, which is what she's putting together right now. A lot of hospitals have separate tables, but this table is pretty fancy. It has all these wingdings. But regardless of what kind of fracture table it is, this has to be assembled every time and taken apart pretty much every time. Fracture tables are predominantly used for like IM rods of the femur fractures, sometimes tibial fractures, but mostly femur fractures. The reason the legs are suspended like this is so that C-arm can get in between the legs. And
one of the things that we need to be cognizant of is that the C-arm does not hit the patient, because they'll want to turn the C-arm, they'll want to do an AP, like anterior posterior image, and then they'll want to turn the C-arm to do a lateral image. So when it's turning, it's going to be right in between those legs up by the affected leg, and you just want to watch really carefully. Oh yeah, yep. Yeah, lap chole, right? Now it's kind of putting the pieces together a little bit more as far as positioning. So they've moved on to something else now.
So like with some of these more intricate pieces, would it be just one person putting the tape together, or would the circulator be assisting?
A lot of times the surgeon will come in and help put it together too. But yeah, usually all of this stuff gets put together even before we start opening. Like, you know, we'll get all the stuff in the room, build it out, and then we open, and then we bring the patient in. But a lot of times the surgeon's there to help. This one, go away, I don't want to see that. This one is good for if you need traction on the tibia. So patient would be laying here, and then the knee goes over this bar here, and then they can put one of those boots, and then it has like a crank with a ratchet. So if you have a tibial fracture and you're putting in a rod, you can't have that bone like this, or it needs to be pretty much spot on, because you're going to go down, you're going to put a rod down the canal, down the medullary canal of the bone. So this device would give you traction on the tibia, whereas the first one is going to give you traction on the femur, if that makes sense. And then I don't know if you saw that big post, but that big post goes in the patient's perineum. So the patient is literally, that's what's holding them on the table. Those boots are pulling on the patient's feet, and their perineum is what is keeping them on. And so usually we pad that a little bit more. I remember the first time I saw that, I was mortified. Let me look at Ian's question really quickly. With setups like this, what are our standards for keeping the area sterile as possible? Are there time limits for when to set up in relation to the surgery? Yeah. So typically what we'll do is before we even open, Ian, we're gonna assemble, if we're using this type of bed, we're gonna assemble this stuff first. So nothing's gonna be open and sterile yet. And then we'll bring our stuff in, we'll go through our stuff, make sure we have everything that we need, we'll open all of our stuff. So typically that's the way that it goes. And then, you know, things proceed as normal, bring the patient in at whatever time after that. But if we're going to do a procedure like this, and I would say if it's not a to follow case, like you just had this case and then as fast as you can get ready, you're getting ready for the next case. We call that a to follow. If it's not a to follow and it's a scheduled case, I would probably start prepping for this case an hour before it started, because you have to assemble all of this and get all of this equipment together. Then, you know, that's probably going to take 20 minutes to half an hour. And now you're about a half an hour before, good to open and go forward. Having said that, a lot of times what they will do for the hip, the previous one that we saw where the legs are both in boots, for a femur, we have a special drape. It's literally called a shower curtain drape. It has a number associated with it. But that's what we typically call it in the field, is a shower curtain drape. And we take 2 IV poles and we put one at the head of the bed and one down further from the feet. And there's a pole, like a long pole, that we slip through the little loops of the IV pole. Are you with me? I know, sounds kind of weird. And then the drape gets stuck to the patient, like the side of their leg, right? And then it opens way up and goes over that pole, just like a shower curtain is on a pole, right? On that rod. So, and it has a sticky. So, and then the C-arm will be on that other side of the shower curtain. So we keep this side sterile and then that side is not. Does that help answer your question? I can show you a picture of the shower curtain drape after this if it's a little hard to visualize. Yeah, okay, you're welcome. Let's skip to something a little bit different. Skip to my loo. This bed's super fancy. If I had an OR and a lot of money, I would buy this bed. Probably most hospitals don't have this fancy of a bed. Or maybe I just worked at 4 hospitals, I don't know. See, again, the whole premise behind this, if with a forearm fracture, is to get traction on radius ulna, right? Or whichever one's broken, or maybe both of them are broken, who knows? So this is going to allow them to distract, right? Because when a bone breaks, if it gets displaced, it can go like this, right? Because the muscles are still pulling on those bones. And so it's going to cause it to be displaced even more. So putting traction on that, we're able to bring it out to length instead of having to use brute force to distract the bones. This is like fantastic. If I was an orthopedic surgeon, I would demand that my place have this. Okay, moving forward. So let's skip to, that's upper arm surgery. This is for shoulder. So what he's doing to the bed right now, we typically, there's an extra positioner that will just go on like a regular table. It's called the beach chair. So that's what he's making here. You can see this is where the well arm would be, the non-operative arm. This is what's gonna hold the head. See how it's holding her head there? And then this is the operative arm, and that piece comes away so that we have access to the shoulder, both front and back. A lot of times with this, they will have another device that like is this right angle here, and it's a special stockinette, like sock, that goes over the arm that we like wrap onto the arm, and then there's a hook on the end, and it hooks to this right angle device, and it holds the arm out like this. So it distracts the shoulder, or like opens that joint up a little bit more so that they can have better visualization if they're doing a scope procedure. If they're doing an open procedure, slice and dice, okay? So for a knee scope, there's a couple different ways surgeons will do them, and I've worked with both types of surgeons where one will use this knee holder, and it's literally like a clamp that like clamps onto the mid thigh here, and that allows them to get distraction in the knee joint, like how he's holding on the bottom part of the knee here. They can pull out on the joint. Might be called a shuck test. I'm not 100% sure. So some surgeons will do this, take the bottom of the table away, and we will drape this leg so it's hanging freely. Other surgeons just leave the table in its normal orientation, and they don't use this leg holder or anything. It's just the patient is in supine. So it just really depends on their preference. So these are the Allen type stirrups. Oh man. I was just gonna talk about that tray that she was putting on the bottom there. So sometimes the surgeons, GYNs, urologists, I've seen GYNs more do this, that they like a tray, like the patient's bottom is gonna be right here and there's a cutout. So once the patient is asleep, they'll scoot the patient, down if they need to, so that their bottom is almost hanging off the table, but not quite. It's not good on the lower back. But a drape can go over this pan right here, and it kind of serves as their immediate use tray. However, a Mayo stand tray that's been sterilized can, they can sit that in their lap as well. But let me see what Rainey's question is. So Rainey, in response to your question about Allen or candy canes, what I have experienced is urologists typically use the Allens, where GYNs typically use the candy canes. The candy canes get a more severe lithotomy where knees are back by ears almost. So you get more of an exposure, especially if you're doing like a vaginal hysterectomy, like you need that space that's created by the candy canes. And then for the urologist, like I said, most times, I'm trying to think if there's ever been a time that I've done urology, and I did a fair amount of it, pretty much used Allens. It's not nearly as severe as, legs are kind of, femurs are almost parallel with the ground, and the knees are down. So legs are kind of out and, legs are down. So that's been my experience. But I think at the end of the day, it does just boil down to surgeon's preference. Having said all of that. Yes, ma'am. You can tell none of that's ever been used in a real OR before, because it would be stained with betadine and it would like have sticky tape stuck to it. So this doesn't show the actual getting the patient into position. One thing that we want to think about with lithotomy position is two people need to lift the legs into the stirrups. So legs need to be raised and placed simultaneously, and raised and brought together and placed back down simultaneously. So you don't want to just be one person where you lift and place this leg and you lift and place that leg, just for safety of the patient. You want to do that with lithotomy position. I know, right? That's yeah. I agree, Rainey. So there's that well arm holder I was talking about yesterday. Remember when I kept saying sometimes instead of pillows they use a well arm holder? That's the well arm holder, this guy right here. See anything wrong with this picture? Which leg is typically bent, the bottom or the top?
The bottom.
The bottom. They never ask her if she's comfy. Another feature that the OR table has is right here. They have something called a kidney rest, and there is a button on the remote that says raise kidney rest, and that's going to push up on the that lateral, that side, that flank, I guess is the word I'm trying to look for, so that it helps kind of open, create a space between the pelvis and the rib cage. So not all the time for laparoscopy do we need this positioning, this modified supine for the patient. If it's like a GYN, like diagnostic laparoscopy, you might see something like this with the legs raised a little bit. Also for like a lower sigmoid colon resection, when we do those, patient is going to be in this orientation or in Allen stirrups. And the reason being is because the stapling device that we use to put the colon back together, first of all, the sigmoid is very low, right? It's that last little squiggle of the colon. So to put that back together, we use something called a transluminal stapler, and it is inserted through the rectum. So we do all the work, the surgeon does all the work in the abdomen, takes out the specimen, and then when you get ready to hook things back together, the assistant is going to take the transluminal stapler, go down between the legs, insert it into the rectum, and then the surgeon will be able to connect this other little adapter that goes with it that he or she has sewn into the other end, the proximal end of the bowel, and they'll snap together, and then the assistant's going to fire the stapler and it will cut in a circle. So you literally have these two blind end tubes, and it's going to cut and staple those two ends together. So that's very helpful for that. Although when you do these cases, it's really difficult as the surg tech to find where you actually belong, because it seems like there's hardly any space here. This is where we usually stand, right? But now the legs are out. So typically we're over one leg on whichever side, opposite the surgeon. Strama. I don't know that we need to look at strama. Okay. I think that's about it. Questions about any of that stuff? Other questions? You can see how extreme some of those positions are.
You were saying that this table's really fancy. So like, is it still pretty common the way that we will be setting it up? Like
Yep.
most of that equipment can be basic equipment, I guess.
Yep.
Okay.
It's going to be a lot similar, except for like all of these pieces come with this bed. But a lot of times what hospitals will do is they'll buy the basic OR table, and then they buy all the attachments that can just hook on to the side rails. Like they're not specific to any bed. They're, able to adapt to whatever bed has side rails. So very similar equipment. Like I said, sometimes they'll have like a separate fracture table. And one thing that it didn't show too much about spine stuff, but there are different positioners for spine that just lay right on top of the OR table. And then for like the shoulder, for the beach chair, what I've commonly seen is it's just a piece that fits onto the regular OR table as well. You just turn the OR table, you put the foot all the way, or you pull the foot off, and then the beach chair slides onto that, onto the side rails, which takes a lot of fuss and muss a lot of times. So, but yeah, pretty much the same stuff that you'll be seeing out there. Yeah, good question. Other questions? Okay, well, I think it's time for a break. So let's do that. Let's see, it's 8:52, so how about a couple minutes after 9, we'll pick things up. And so I'll see you then. Okay, thanks. You are absolutely right. This is the areola marker. It is used to mark the areola. I like it when they keep it simple. Okay. What about this device? The keyhole. Yep, McKissick keyhole, right? They're gonna center the areola here, and then they're going to trace this entire thing. That's gonna tell them where to make their initial incisions for mastopexy or for breast reduction as well. I remember the first time I ever saw breast reduction, and I wondered how the breast was ever gonna come back together to look like a breast. Like, I don't know how they do that. With mastopexy, I can see the end result as they're working, but with breast reduction, it just seems like, I don't know. I'm glad it's them and not me, but I just could not see how that was going to come back together, but it does. All right, what about this guy? The mesher. And so what disposable piece is missing from here? What did I say we put the skin on? Anybody remember? A little plastic card, yeah. Like a little, it's a disposable, you know, it's probably 3 or 4 inches wide and about 6 inches long. It has little ridges on it. So they're gonna lay the skin on that, spread it out nice and evenly. I think sometimes they call it the carrier. Okay, and the surgeon usually monkeys around with the skin graft because you don't want to be responsible for messing that up. Let them do it. Unless for some reason you work with this person all the time and you're trained and you know you are comfortable with it, just like let them do their thing. Okay, this is a very heavy, like weird piece of equipment. I usually put down an extra towel and then set it right on the very corner of my table with this handle. This is gonna freak you out, hanging off right over the edge. So this would be along the edge of my table because sometimes, most of them, that handle goes all the way around. All right, and they're gonna need to be able to do that. And if it's not shifted over, then it's gonna hit your table. So something to think about. The school does not have one, unfortunately. We do have a long list of stuff, but I do not have a dermatome and I do not have a mesher. But maybe I should sick Mrs. Braunbeck on that task. She seems to have a knack with getting those things. So I'm going to put that on her list of totos. All right, the mesher, the derma mesher. Okay. And what about this one? The dermatome, yes. And this is the air-powered one. Anybody know what type of medication we might need when we're using this? I don't know if you really call it a medication, but it's a pharmaceutical, that, or we would have to get it from pharmacy anyways. Anybody know? It would be something that we would put on the skin before we use this jigahoozy. It makes it slide easier. Good guess, good guess. Lidocaine and iodine are good guesses. We actually avoid prepping the donor area with betadine. We typically prep it with something that is not a color, you know, like Hibiclens or something like that. And in response to the lidocaine, sometimes they do use like Lido with Epi topically after they take the graft. But before they take the graft, most times they will put mineral oil on the skin. So see, it's not really a medicine per se, but we do have to get it from pharmacy. And so they'll take like a tongue depressor, you know, and they will spread it on the skin, and that's going to help the dermatome like glide along the skin more, you know, more efficiently. They don't want to go skipping down the skin because that's going to damage their graft. All right, what about these? Yep, dermatome blade. Is this multi-use or single-use item? Yeah, single use. And so when we're done with surgery, where do we put this? Yeah, in the sharps. And surge techs never let other surge techs handle their sharps. Okay, get rid of your own sharps. All right, what about this? What about this? Nice. Yes. Good job, Alyssa. Even got the Watson in there. Lixie too. Good job. Watson Skin Graft Knife. Has a disposable blade as well. And this is man-powered, not air-powered, right? A lot of times I use it to clean up I see them use it to clean up the recipient site, but not to say that they can't use it for taking a skin graft as well. Nice. Okay. What are these? Yes, the curved iris. Make sure if you're ever to identify them, like writing down an answer on a test, that you would say curved iris scissor, because there are straight irises as well. Okay. Good
About
job.
how long are they?
They're really small. They're like about 3 inches, 3
Okay,
or 4 inches long. Yep.
thank you.
Yep. They're T9C, as my grandma would say. Okay. Good job. Iris scissor. What about this scissor? Yep, the facelift scissor. You're right. They got these long, kind of tapered blades. Good job. Next. Yep, the littler plastic scissors. Not the bigger ones, the littler ones. Littler. Yeah. And I think they're distinguishable from the facelift scissors in that, check out the facelift scissor, how the blades are a lot longer and tapered. And then these guys are shorter from the box lock to the tip.
Why does it look like it's got a hole that goes kind of through and through? If they were close together, why is there that hole there?
Good question. I do not know why
Okay.
why that's there. And the facelift scissors that I have worked with, actually on the outside of the blades have like this ridge that runs down them. And they're either straight or curved. So this one that is in the book, I'm not as familiar with.
There's a little blip and it says instrument insight and it says holes on blades serve as suture carriers.
Okay. Yeah, I've never seen this actually used in surgery ever. Rulon, shout out. Have you ever seen this one used in your trays where you work or anything? Yeah. It's kind of strange. Like, does it seem like sometimes people that write textbooks know too much information? You know, like, tell me the general stuff that I need to know, but not the crazy stuff that I'll never see, but the most common things that I'll see in this, I've never seen it either. So anyways, having said that, you probably won't either. But then maybe you'll come back and say, Miss Windsor, there's Dr. So-and-so, and like, this is his favorite scissor. So you never know. Okay, what about this one? Stevens, what? Yes, Stevens tenotomy scissor. Yep. I might have seen straight ones in my life, but curved ones are the most common that I've seen.
What about this one? Yep. Yep. Mammoplasty hook. See, I was able to animate these parts okay, but I couldn't figure out how to do one answer. Oh, oops. That was premature clicking. Okay, here we have the Joseph single skin hook. Joseph single skin hook. Okay, I'll try not to do that again. What about this one? Yeah, the double trouble skin hook. We call it the double wide. Okay. We had one in school in the lab that we were using yesterday that is a little bit narrow, a narrower one. The blades are closer together. Okay. Very good. What about Visa one? Oh, buddy knows. Buddy knows. Yes, the cottle. The cottle. The single cottle. Much more right angle than our little Joseph skin hooks. Nice job, Ivana.
You know, do they always have like that flat handle, or will they sometimes have a round handle, but it's based on the 90 degrees?
I've pretty much only seen flat handle ones.
Okay, thank you.
I think it's kind of a characteristic of them. You're welcome. Okay, so what about this one then? Yep, you got it, Rainey. That's the double cottle tenaculum. There's also a cottle knife, or they call it a button knife, and it has that same handle, but it's just like a little, I have one in the lab I can show you guys the next time you're in. All right, what about this one? Yeah, Matthew, I'm calling it sin. I don't know that there's much difference between the two. Yeah, in the book it's called a Matthew. I've never heard it called a Matthew. Okay, now, Alyssa. This one is our Meyerding. We also have orthopedic sized Meyerding, which looks almost exactly like this on the end, but it's a lot bigger, about that wide and about that long with a handle. Not this finger loop thing at the end though. Meyerding finger retractor. And here we have the Ragnell retractor, Ragnell. Very good. And what's this one? He went to Jared's. Yep, you got it. Wheatlander's sinister cousin. Do you love this one, Tori, as much as you love the Wheatlander, though? It's the Jarrett. Also heard it called the Heiss. One place I worked. What's this weird thing? Weedy for life, Tori said. Are you going to get that tattooed somewhere? You could have it like, yeah, and then it could be like retracting and like exposing something underneath. You could like get a little incision, like could like some of your little vertebrae like showing through. That would be awesome. We could all get matching ones. Okay, yes, Rulan says this is the mammoplasty retractor. The Briggs mammoplasty retractor. Very good, very good. I think there's only.
So how does that work? Like, does it go under the breast and retract? Like, I don't understand the curvy of it.
Yeah, so where I've seen this used the most is when they're like making the pocket to receive the implant. So they're kind of making like a little pouch in there. So if you can imagine that U shape, you know, you're holding on here, this part is in the pocket. So that you can kind of like toe in and like raise it up. So a lot of times the surgeon will want to take it from you, you know, and as they're working, they're holding the handle and it's inside the pocket, you know, like that. And they're using it to kind of toe up so that they can, and they'll use like a long cautery tip and they're just kind of cauterizing in there. I've seen surgeons get down on their knee before and they're like, their face is in the pocket. And anyways, don't get too twitchy because, you know, see them do that. What else was I going to say? Oh, so this was where the last time when we looked at these, I was talking about how they have lighted breast retractors too. And they have like a little doohickey, a little nubbin back here where the light cord can attach to, and then light, it doesn't look like this. It's just like a big right angle, you know. And then the light comes out the end, you know, of it. And so that helps them shine some light on the subject because they're working in this dark hole pretty much. Awesome. Okay, what about this? Yes, 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 lipocannulas. They come in a variety of sizes. So sometimes you might have like just a tray that's like liposuction cannulas, and there might be a dozen of them in there. Yep. It's like a fat straw, right, Ian? All right, good job. Couple more left. So look closely at in there. The way that we tell these two apart is that here. So Webster, yeah, sorry, Jacob, I clicked before you were answering, but smooth inside the Webster, all right, as opposed to its sinister cousin that has the rough, yes, the Halsey. Yep. Okay. Ta-da. So rough and tumble on the Halsey and smooth on the Webster. Webster's a smooth operator, okay? Okay, that's a review of our instrumentation. Questions about any of those? Questions about anything else? Okay, fine, folks. That's all the entertainment I have for you today. Thank you for your participation. Oh, Alexis is asking the Halsey versus Webster use? Same use. Fine suture needle working in like superficial area. I think it probably just boils down to surgeon's preference as far as which one is used. good question.
Is there
Anything else?
with the Matthew and Sun Retractor?
Yeah, they're
Benefit?
probably the Matthew's going to be thrown in for a sin. Is my guess. They're, you know, I think the biggest, if there is a biggest difference, is how sharp those little retractor talons are. You know, but yeah, I think it's just surgeon's preference. They're both going to do the same thing.
Is the Sun smaller and Matthew bigger, or are they both the same size?
I think they're roughly the same size.
Okay.
Yep.
Now for the LVL, are we just posting the quiz thing we did?
Yes. So for the LVL, thanks, Jonathan. Just go ahead and post the link to the question Google Slides that you guys did, okay? And that'll be that. Anything else I left out? Forgot to say? Questions in your mind? Okay. Then don't forget at 11:30 to take your quiz, okay? And I will see some of you in lab tomorrow. All right. Don't forget to bring your workbooks. If you want to pre-name and pre-date your paperwork, that would be great. Okay. You guys have a good afternoon. I'll see you tomorrow. Bye.
Ms. Windsor, I delete the Google link. Can you resend that or
Oh,
so I can post?
yeah.
Sorry.
Hold on one sec. Let me get that for you. I'll put it in the chat, okay, Rulan? All right, do you see it there?
Awesome. Thank you.
You're welcome.